She has the rat poison and a plan. She's experienced sexual abuse, intimate partner violence. She's HIV positive. Her disease is progressing, and she's about to start antiretroviral treatment. She lives in extreme poverty, where access to mental health treatment is close to non-existent. She's actually a potential participant in our study on HIV and trauma. Over a short period of time, just this past summer, on average, 1 of 5 HIV-positive women screened had to have an emergency psychiatric referral. She had the poison and a plan. She was put into an ambulance and taken to a psychiatric hospital. Fortunately, one actually exists in Cape Town. The purpose of our study is to screen for traumatic experiences to address the psychological consequences of the trauma and its impact on HIV care and treatment. Our work to date actually indicates that more than half of these women have experienced sexual abuse or rape, and almost all of them intimate partner violence. So it won't surprise us if she had depression or post-traumatic stress disorder before her HIV diagnosis. I asked our project coordinator, with this sudden increase in need for psychiatric referrals, how did she feel? How was she doing? Her response, angry. No one seems to talk about the chronic stress that these women experience every day. No one asks her how she feels emotionally. No one wants to talk about it. So who will speak up for mental health? We have to bring its importance out of the shadows. But let's just talk about how common mental illness is. 1 out of 4 people around the world experience mental illness in their lifetime. That means us, all of us in this room, on this campus, in this country, in South Africa, worldwide. Among youth ages 9 to 17, 1 in 5 have a psychiatric diagnosis that affects their daily functioning. We actually know that most adult mental illnesses have an onset in childhood or in youth before the age of 25. We know that 90% of young people in the world live in low and middle income countries. And those countries have the burden of 75% of the global suicides. So the math should tell us what to do. With suicide as the 2nd leading cause of death among females and 3rd among young males, we are distressed but not surprised by the rat poison. Yet, at best, 50% of people with mental illness receive treatment. And in low-resource settings, like the ones that we work in, 9 out of 10 people with mental illness do not receive treatment. Sorry, there's something wrong. I'll figure it out. With such a burden of disease and no providers, how does mental health contribute to the global burden of disease? It's currently 3rd. Depression ranks 3rd. But within 15 years, in 2030, depression is expected to be at the very top, the single greatest contributor to global disease burden. If we want to talk about the money, the costs associated with mental illness are currently at $2.5 trillion, expected within these 15 years to go to $30 million. So we can't neglect mental health anymore. Think about these diseases: PTSD, depression, bipolar disorder, addiction, dementia, schizophrenia, autism, anxiety. What do they evoke in you? Do they evoke a different response than when I say cancer, AIDS, diabetes? We have to address the stigma that's involved in mental illness in order to begin to affect change that's needed. When it comes to mental health, all countries are developing countries. This was recently said by a global mental health expert, Pam Collins. What does this mean? This means that nowhere are there sufficient mental health providers. So how are we going to handle this problem? which from my point of view maybe should be at the top priority of global health. But how we're addressing this issue of not having enough mental health providers is actually the idea that non-specialists can deliver mental health treatment. We call this task shifting. We're all about task shifting. This has actually been used in many other areas and diseases: AIDS, malaria, TB, maternal and child health. And the idea is that we have to question our assumptions that mental health treatment must be delivered by specialists, and that we can move towards the delivery by non-specialists. For example, this is a group of female health volunteers in Nepal undergoing a training to reduce the stigma related to mental illness among both community members and providers themselves, so that they can potentially deliver mental health services. What's different about this approach, particularly in mental health and the stigma involved, is that we cannot just bring our Western models. We must adapt them to culture and context, and we must also work with local community members and families so that they can be a part of the solution. It's really about empowerment and social change. And that's what makes working in global mental health global mental health unites the field and the science with the cause, so that we actually really have to work towards social change in this disease area. So how are we doing this at DGHI? Our approach is interdisciplinary, of course. We have many projects that range from working with children to elderly people across a range of disorders: PTSD, depression, schizophrenia, addiction. We also have a great focus on how mental illnesses and mental health is comorbid with other conditions like cancer and AIDS, and can also be addressed to improve the effectiveness of that treatment. And our approaches are interdisciplinary. We have prevention approaches as well as implementation science and effectiveness, and I'll give you some examples of what we're doing right now. For example, we are working to develop culturally appropriate diagnostic and treatment approaches in autism and other neurodevelopmental disorders in South Africa. As mentioned by Brandon this morning, in earthquake-affected areas, we're working to prevent suicide among adolescents in school settings. Using family strengthening and church-based approaches with the support of church leaders in Kenya, we are working to identify at-risk youth so that they can hopefully actually prevent mental illnesses from occurring. We have multiple projects related to maternal and child health, including focuses on depression and substance use. Then there is this endemic, of course, of HIV that I had mentioned, why we try to intervene to reduce the effect of trauma, gender inequality, poverty, and relationship violence. In situations where there are providers, we are working to disseminate effective ways of providing depression treatment. And of course, right here at Duke, at home, we have a great energy about global mental health. The undergraduate interest sometimes overwhelms us, and we are pleased that we have a number of faculty working in this area. No health without mental health. This was the title of a Lancet article almost 10 years ago. We do know that mental health is an important part of global health, but it has gone unrecognized and continues to be under-resourced. So we must talk about it, and we must do something about it. We in global health have done this kind of thing before. We have made change. We can look at all the progress that we made in AIDS in the past 35 years. Myself, I have worked in AIDS, mental health and AIDS for 30 years. And if I stop and think about what we've done, many of you in this room have had some of those same experiences that we've done with our mind and our hearts and our hands and our feet to make change. Reflecting back in my early years in the 80s, and think about this in parallel to mental health, we had no treatment for many years, insufferable deaths, hidden funerals, and now we have a chronic, lifelong disease. Through social action and political advocacy, we were able to get the FDA to fast-track drugs and to have AIDS expedited review to this day for our grant applications. In 2002 in Barcelona, I heard Yup Longa say, We're going to get the meds to $1 a day when they cost $15,000 in the United States, and we're going to get them around the world, and we've done that. And in South Africa, where I work, where there's a former president who was an AIDS denialist, saying that HIV does not cause AIDS, this month South Africa has test and treat. So as soon as you're known to be positive, you can get treatment. Think of the parallels to mental health. In AIDS, we talk of cure. We talk of an AIDS-free generation. We know we can make change, and we must make that change in mental health. So for all of you that are with us in mental health, let's do more. For those of you who are interested or work indirectly, please join us. Are we going to talk about mental health? Yes, we are. And yes, we're going to move the agenda forward. And by the way, no more rat poison. Thanks.